Just be happy with who you are. Just be happy with who you are. Just be happy with who you are.
Hi, and now we're in Chapter 9, Gender Dysphoria, Paraphilic Disorder, and Sexual Dysfunctions. So let's consider attitudes towards sexual activity are incredibly diverse. Now, what is normal, I should put it in like this, is clearly influenced by socio-cultural factors. Sexual behavior may be labeled as abnormal if it deviates from the norms of whatever society we happen to be in. It may also be labeled as abnormal if it's self-defeating, harms others, causes personal distress, or interferes with one's ability to function. So we're going to consider a couple of people here. Sally and Dave. Sally and Dave decide to seek therapy after only 8 months of marriage. Both were extremely dissatisfied with their sex life. Dave complained that Sally never initiated sex, found excuses to avoid it, and appeared to fake orgasms during intercourse. Sally complained that Dave's lovemaking was often brief, perfunctory, and without affection during the therapy sessions. It became clear that Sally had never had a strong interest in sex and seldom became aroused during intercourse. Although Dave had never had difficulty with maintaining an erection, sex with Sally had become progressively distressing, and he often had difficulty getting hard enough for intercourse. Now, the case of Sally and Dave illustrates that psychological and physiological complexities associated with one of these 3 groups of disorders we are going to explore, or we'll be reviewing in this chapter. Sexual dysfunction, which involves problems in the normative sexual response cycle. The other 2 disorders are gender dysphoria, distress resulting from the incongruence between a person's gender identity and assigned gender, and paraphilic disorder, problematic sexual interests, fantasies, and behaviors. Now, we're going to begin with a review about what constitutes normal sexual behavior and conclude this chapter with review of sexual dysfunction. Now, for this chapter, we're going to look at a description of the disorder, the theoretical perspectives, and treatment for each group, one group at a time. Now, this follows the chapter, however, it makes for a longer video rather than 3 separate ones, so let's start. In gender dysphoria, an individual experiences significant personal distress or impairment functioning as a result of discrepancy between his or her anatomic sex, biology, and gender identity, and it's influenced strongly by socio-cultural factors. Transgender identity is the type of gender identity that a person has a psychological sense of being in one gender and possessing the sexual organs of another. And it's quite disconcerting, of course, as you can only imagine. Now, not all people with transgender identity have gender dysphasia disorder, as many are not distressed about their identity and have accessed the support that they've needed. Gender dysphoria pertains to people who find their anatomic gender to be a source of persistent and intense distress. People with this disorder may seek to change their sex organs to resemble those of the opposite gender, and many undergo gender reassignment surgery to accomplish this purpose. It is important to understand that sex and gender are not interchangeable. Sex relates to our biology, and gender is socially constructed. Part of the issue with gender is how we tend to treat it as sort of polar opposites, men and women. However, gender is on a more of a continuum, men at one end and women at the other end, and many variables in between. In our North American culture, we generally see 2 genders. However, other cultures, the social construct has sometimes more, 3, even 5 different socially accepted genders. It really reminds us of how connected gender is to culture in society. So the theoretical perspectives. The psychodynamic theorists point to extremely close mother-son relationships, parents with empty relationships, and fathers who were absent or detached, or girls with weak and or ineffective mothers and strong masculine fathers may develop stronger little men identities and behaviors. Being able to look back into childhood experience is certainly a lot of what the psychodynamic is about. The learning theorists, they have a similar focus where socialization patterns have a big effect. They point to father absence in the case of boys and to the unavailability of a strong male role model. However, not the sole responsible feature in the development of gender dysphoria. To better understand, read the story of Bruce from Winnipeg. That's in your textbook. And there is more than socialization or parenting style that to the development of gender dysphoria. You need to consider a biological predisposition, considering the gendered brain and the role of sex hormones. Prenatal hormonal imbalance may also be involved. Perhaps the brain is masculinized or feminized by sex hormones during certain stages of prenatal development. So what about treatment for gender dysphoria? Recommended treatments for gender dysphoria include hormone therapy, real-life experiences, that is, living as an in the identified gender that you identify with, sex reassignment surgery, and psychotherapy. But not everyone with gender dysphoria seek gender reassignment. Some of the more known people that you may have heard of, Chastity Bono, the daughter of Sonny Bono and Cher. The picture on the left is Chaz Bono. In the right, in 2011, Bono had gender identity disorder and would undergo the hormone and surgical procedures to transition from female to male. The woman on the other woman there is Jenna Telkakova, was a Miss Universe 2012 contestant. She finished in the top 12 out of 62. And of course, Caitlyn Bruce Jenner. Of course, these are individuals are the more famous, if you will. There are many other people not so famous who have pursued gender reassignment. Now, we're moving into the paraphilic disorder, and we're going to review the types of paraphilic disorder that there are. Paraphilic disorders are the type of sexual disorders in which a person experiences recurrent sexual urges and sexually arousing fantasies involving non-human objects such as articles of clothing. Inappropriate or non-consenting partners, for example, children, or situations producing humiliation and pain to oneself or to one's partner. The person has either acted on such urges or is strongly distressed about the urges that they have. Now, there's two types of paraphilic disorders discussed in our text, including the types that we're going to talk about at least. Exhibitionism or exhibitionist disorder, fetishistic disorder, transvestic disorder, voyeuristic disorder, frauderistic disorder, pedophilic disorder, and sexual masochism disorder, hypoxophilia and sexual sadism disorder, and sadomasochism. Quite a collection. Quite a collection. Now, some people diagnosed with paraphilias can function sexually without the paraphilic object, and some cannot. Some people with paraphilic disorders are men. Women may also have been overlooked in the research. We're going to review each of these. We'll look at exhibitionism. It's a recurrent and powerful urge to expose one's genitalia to an unsuspecting stranger. They are not interested in contact. Most just want to participate in the fact that the response, the surprised look, the disgust, the shock, or the sexually arousal of the victim is what they're after. Is that effect? Fetishistic disorder. This is the reoccurrent and powerful sexual urges and fantasies involving inanimate objects like clothing, or a body part, feet, or situation involving sight, smell, or feel. Transvestic disorder, reoccurrent and powerful urges and fantasies to cross-dress for purposes of sexual arousal. Now, this is not the same as gender dysphoria, as men are typically heterosexual and do not consider themselves a woman. Voyeuristic disorder, urges and fantasies involving the fact of watching unsuspecting people while they're getting naked, or naked and engaging in any sexual activity. The person either acts on these urges or is very distressed about having the urges or fantasies. The frotteuristic disorders, urges and fantasies involving the rubbing against or touching a non-consenting person. Again, the person either acts on these urges or is very distressed about having these urges and fantasies. The paraphilic disorder, a reoccurrent and powerful fantasies and urges involving sexual activities with prepubescent children. Now, this is particularly damaging disorder. It can have long-lasting consequences to survivors of sexual abuse. Now, although some paraphilias are essentially harmless, such as fetishism, some, such as pedophilia and sexual sadism, often harm non-consenting victims. Now, the development of a persistent sexual offending against children sees two pathways: antisociality, and second is sexual attraction to pubescent, and that's the pedophiliac. The presence of both indicate a very high likelihood that the person will offend against children. Now, sexual masochism disorder is sexual urges and fantasies involving receiving, humiliating, or pain. It's either acted on or the person is distressed about having these urges and fantasies. This can include the dangerous forms of masochism and hypoxophilia, or autoerotic asphyxiation, arousal through the restriction or deprivation of oxygen. It's very risky. Sexual sadism disorder, these are the urges and sexual urges and fantasies involving inflicting humiliation and pain on a sexual partner, either acted on or distressed about those urges. Sadomasochism is the sexual activity between partners involving gaining gratification by inflicting and receiving pain or humiliation. Now, the other paraphilic disorders, many and varying ones. We're not going to go through all of them. The theoretical views, well, psychodynamic theorists see paraphilic disorders as defense against the leftover castration anxiety from the Oedipal period. These forms of psychodynamic theories are speculative, as there is no direct evidence for this. Now, learning theorists explain paraphilic disorders in terms of conditioning and observational learning. Some objects or activities become inadvertently associated with sexual arousal. Paraphiliac disorders may involve multiple biological, psychological, and sociocultural factors. As far as treatment of paraphilic disorders is concerned, therapists of various theoretical persuasions have attempted to treat clients with paraphilic disorders. Psychoanalysts, for example, attempt to bring childhood sexual conflict, typically the Oedipal nature, into awareness so they can be resolved in the light of individuals' adult personality. Behavior therapists often use aversive conditioning, for example, electric shock, to induce a negative emotional reaction to paraphilic stimuli or fantasies. Selective serotonin reuptake inhibitors, or SSRIs, are used in treating exhibitionism, voyeurism, fetishisms. These are the biological approaches. Researchers think there may be a relationship between fetishes and OCD. Efforts to treat paraphilia are complicated by the fact that most people with these disorders do not wish to change. Now, this next section is not a disorder in the traditional way, but we'll look at sexual assault. Sexual assault is a violent crime and not a sexual disorder. The desire to dominate women or express hatred toward women may be more prominent motives for rape than sexual desire. The sociocultural perspective suggests that cultural attitudes such as stereotype of male aggressiveness and social dominance underlies the propensity to rape. Rape survivors often suffer a range of immediate and long-term effects. So as far as sexual assault, we're not going to cover this topic as it's not a psychological disorder and it's not in the DSM-5. This is not meant to diminish the seriousness of sexual assault. Sexual dysfunction. Now this is another category and it was referenced briefly in the introduction. Sexual dysfunctions involve patterns of sexual interest, arousal, and responses and can be grouped into the following categories. 1. Disorders involving problems with sexual interest and arousal. 2. Disorders involve problems with orgasmic response. 3. Problems involving pain during sexual intercourse or penetration. And this is predominantly, of course, as you would expect in women. For a diagnosis to be made by a clinician needs to determine that the problem is not related to the use of drugs and medication, other conditions such as severe relationship distress or other serious stressors that might be causing the personal distress and having lasted at least 6 months. So it's got to have been for a while and for reasons that are not drug related. So disorders of sexual interest or arousal, there are 2 separate disorders related to men and women. Male hypoactive sexual disorder, desire disorder, and female sexual interest arousal disorder. And as you may have thought, what is normal level of desire? Much investigation needs to go into the diagnosis as there are many variables to consider. Male erectile disorder is related to attaining and maintaining of an erection. This does not include the occasional difficulty, but for persistent and reoccurring episodes. Orgasm disorder includes 3 types of disorders. Female orgasmic disorder, this is the inability for a woman to achieve orgasm, or for a man premature ejaculation or delayed ejaculation, which is either the absence of orgasm or persistent reoccurrent delay of reaching an orgasm. The gentio-pelvic pain penetration disorder is diagnosed by persistent or reoccurring pain experienced during vaginal intercourse or penetration attempts with 4 primary symptoms. Some forms of genital-pelvic pain penetration disorder involve vaginismus. Sorry, I am sorry. I practice these, but when I come out with them, they don't come out quite as smoothly. I'm sorry. The theoretical perspectives of sexual dysfunction, like most psychological disorders, reflect the complex interplay of biological, psychological, and other factors. Sexual dysfunction can stem from biological factors such as disease or the effects of alcohol and other drugs. Diabetes is one of the most common organic causes for erectile dysfunction. Testosterone has a huge role in sexual interest and functioning in both men and women. The biological issues are a major cause for sexual dysfunction. Learning looks at the role of conditioned anxiety and anxiety being linked to sexual activity. Thus, learning that sex or sexual situations are anxiety producing. They also look at sexual fulfillment through our trial and error with sexual partners and messages that we have learned from these experiences. For cognitive theorists, irrational attitudes and beliefs are considered here. For sexual dysfunction, faulty thinking, catastrophizing, globalizing, fear of failure, performance anxiety, all fall within our cognitive area. The sociocultural includes such factors as sexually restrictive cultural learning, sex used to be thought of as a male activity. For women, it's been more of a duty. This would not expose women to a higher degree of self-awareness of their own sexuality. So what have we learned? So what we learn from tradition what our roles of men and women are according to our culture, culture will often dictate how we are supposed to behave or perform sexually. This could include media, porn access, can all have an effect. Now, treatment for dysfunctions, treatment for sexual dysfunction, sex therapy focuses on directly modifying problematic sexual behavior by enhancing self-efficacy expectations, teaching sexual competencies involving sexual communication, and reducing performance anxiety. Now, this works in areas of sex therapy was pioneered by Masters and Johnsons in the 60s. Disorders of sexual interest in arousal therapists try to use sexual fantasy and self-stimulation to rekindle the sexual appetite. In some cases, testosterone replacement therapy is used where that hormone is deficient. Disorders of orgasm, the disorders of orgasm, the relationship between anxiety about sex and poor exposure to positive self-awareness about one's own sexual identity. Therapists assist with the reconnecting sufferers with more positive views of sex and one's own sexuality, where masturbation is encouraged to learn about what feels good and what is desirable without needing to attend a partner's needs. The gentio-pelvic pain penetration disorder, vaginismus, is not a physical defect. Rather, it is a psychological state affecting comfortable intercourse. Treatment involves cognitive behavior techniques, relaxation techniques, and the use of a dilator to improve sexual experiences. Now, this has been a really sort of a quick overview. You can see that, the area of gender dysphoria, one, is very complex, but then so is paraphilic disorders and sexual dysfunctions. That usually, as is the case in a lot of sexual disorders, or for that matter, a lot of disorders we'll see, is that the needs for treatment are so complex that you're often using biological, psychological, sociocultural, learning, cognitive, behavioral, all in an effort to make some improvements in the quality of life of individuals. I hope you found this helpful and interesting. I did it all as one, just because I felt it would be hard to really sort of break it up into individual ones. So I hope this has been helpful for you. Good luck, and we'll see you in the next week's videos. Bye now.